Good evening, everybody. Thank you for joining me. My name is Daniel Southern. I am the medical director of Interventional Orthopedics CT, located in Norwalk, Connecticut. I'll give you some contact information at the end of the presentation, which I hope is not going to be too long and too protracted. I'm going to move very swiftly. If you have questions and you jot something down, ask me at the end. I'm happy to spend as much time as anybody wants to answer questions following the presentation. So, the title of the presentation is Treatment of Orthopedic Injuries. And this is just a way to get started and talk about injury in general, how the human body heals itself, the traditional algorithm of treatment of orthopedic injuries, and then a brand new field of orthopedic medicine that treats these injuries and how it serves as an alternative and an option for avoiding surgery for these injuries, should they be required. I'd like to start with just the diagnostic dilemma. When you come into my office, really the first order of business is to get you the best diagnosis possible. And that involves, figuring out why this joint here on the right has failed relative to the joint on the left, which is fine looking. But this one is very, very degenerated and is obviously very painful. And in the history that comes out during the evaluation, quite often what you hear is that there was an injury. Somebody, fell off a fence when they were 16 and landed awkwardly and had pain in their lower back and hip joint for several months before it got better on its own. But then 10, 15, 20 years down the road, the ache returns. This is a common presentation. So injury, as well as surgery, which is a form of injury. It's a controlled injury, to be sure, but nonetheless, it's an injury. A history of injury in a joint is often the reason why a joint has become symptomatic. Orthopedic injuries are injuries to the following tissues: muscles, tendons, ligaments, bones, fascia, joints, and when we say joints, we specifically mean cartilage. And orthopedic injuries occur in play, in sports, in walking down the street, climbing the stairs and tripping. And they also occur with normal aging. A joint degenerates with time and can become symptomatic. All of these orthopedic tissues, with the exception of muscles, I want to exclude muscles here, even though the graphic will include them, because muscles have a good blood supply, but all the rest of these tissues, what they have in common is that they have a poor blood supply, and that's a key concept to this new field of medicine, so I want you to keep that in mind. In other words, they have a limited ability to heal themselves, and that's because their blood supply is not robust. Sprains, strains, tears, and fractures. Ligaments are sprained. Ligaments connect bone to bone. They're very tough, fibrous connective tissue. And you sprain a ligament as opposed to a tendon or a muscle, which you strain. And what we're talking about is injury comes from stress to the connective tissue, causing subcatastrophic or sometimes catastrophic failure of that tissue. And these range anywhere from microscopic breaks in collagen proteins, which are the basis of ligaments and tendons, to and or protein attachments, to complete rupture of the tissues. So keep that in mind. Ligaments can be torn, tendons can be torn, and muscles can also be torn. The stages of healing in the human body. You go through three main stages, the first of which is inflammation. This is when you injure yourself and the area gets swollen and red and hot and aches and throbs. That's an inflammatory process. You want to distinguish this inflammation from the bad inflammation. Bad inflammation is chronic inflammation in the body, and chronic inflammation, without a doubt, is going to kill us all. But acute inflammation following an injury is good inflammation. It is the beginning of the process by which the body repairs itself. So ironically enough, when you reach for that Advil bottle after you injure yourself, you're kind of working against yourself. I would recommend strongly that you reach for Tylenol first, which is a pain reliever and not an anti-inflammatory, because you don't want to blunt the process of repair. After inflammation dies down a week, 2 weeks, maybe even sometimes longer with a bad injury, it begins to transition into the second phase, which is known as proliferation. And this begins weeks to several months after and lasts from weeks to several months after an injury. It's the second stage. It involves the rapid multiplication of cells and the production of collagen proteins that will be used in repair. This is also the stage of angiogenesis. And angiogenesis is the formation of new blood vessels. And this is the key to normal healing, and more about that in just a second. The final phase, which goes from months to several years after an injury, particularly a bad injury, is remodeling. This is the final and the longest phase. This is where all the new tissue that was laid down during the proliferative phase is reorganized and rearranged and realigned into the final array of fully mature tissue, which is that wonderful, strong tissue which you had before the injury and is distinguished from scar tissue, which is a weak replica of what you had before the injury and is vulnerable to re-injury and re-tear. How do injuries heal? Answer in 2 words: blood flow. Blood flow is key. During acute injuries, tissue is torn, bleeding occurs, and with the bleeding into this area of damage, blood brings repair cells to the damaged areas. Notably, the first repair cells to arrive are platelets. These are a small circulating cell in your bloodstream. And there are the first cells to arrive in any area of injury. Their first job is to form a blood clot so you don't bleed to death. But right on the heels of that, they begin to trigger the first step of healing, which is inflammation. The amount of blood flow dictates healing time. Muscles have a fairly robust blood supply, and they heal in days to weeks. But all the rest of these tissues, bone, ligaments, cartilage, they heal in weeks to months, months to never, and cartilage basically doesn't heal itself. This blood supply is so poor. This is where that expression, it's better to break a bone than to tear a ligament. And that's because bone has a little bit better blood supply than a ligament. And a ligament will repair itself more poorly than a bone will, for example. Now, this is a crude approximation of healing, but nonetheless, it's very, very true. The amount of blood in the area, the amount of blood that's supplied to an area dictates how well that area will heal itself following an injury. Back to angiogenesis. This is from 2 words, a Latin angio meaning blood vessel and genesis meaning mode of formation or origin. Angiogenesis means the formation of blood vessels. It occurs during the proliferative phase of healing. It is extremely important. Any disturbance or failure of angiogenesis results in abnormal healing. You can think of new blood vessels, and that's what we're talking about, new blood vessels supplying damaged tissues. You can think of new blood vessels. The analogy here is of roads built to a construction site deep in the woods. You're going to build yourself a fabulous building there. You need access. You've got to get the earth movers in. You have to bring in all the supplies. The analogy is that blood vessels do the same thing. So you need a blood supply to an area of injury. Anything that supports angiogenesis is going to improve healing. Anything that works against it is going to prevent healing or blunt healing. How do injuries lead to arthritis? Well, that's interesting. There's an entity known as chronic post-traumatic arthritis, and this is an injury progressing either, right on the heels of the injury or after a long period of seeming healing and recovery. And that was the bit of history that I was trying to illustrate at the beginning of the talk under that slide, Why This Joint. People come in and they say, I injured myself badly. I was at a roller rink and I fell down and I really twisted my knee and it swelled up and I could hardly walk for a couple of weeks before it got better. And then it was no problem for years and years and years. How many years ago was that? Oh, that was 25 years ago. Okay, well, now we have arthritis, as illustrated here in this ankle joint. This ankle joint is perfectly normal. This ankle joint looks like heck, and this is a joint that was sprained repeatedly. So this is post-traumatic arthritis. Well, let's take another step backward. What is arthritis? Well, in a word, arthritis is joint degeneration. Arthritis begins in cartilage, which is the articular surface covering bone. Once the cartilage breaks down, gets broken up, and disappears, the underlying bone begins to be destroyed. And it's usually at that point when patients show up in my office. As the bone becomes involved, the pain increases. How do injuries lead to arthritis? Well, injury results in cell death, and we're talking about cells that are alive in cartilage, because that's where arthritis begins. The cells alive in cartilage are chondrocytes. The cells alive in bone are osteophytes. The cells alive in ligaments are fibrocytes. The cells alive in tendons are tenocytes. Injury damages these cells, and you lose quite a bit of them, many, sometimes tens of thousands of them. And this is a schematic showing the loss of chondrocytes and what happens. How do injuries lead to arthritis? Injury can cause instability. Not just injury, just normal time and aging can also cause instability. And what instability does, it leads to a chronic injury model of functioning. What that means is that the joint is chronically unstable on a microscopic level. We're not necessarily talking grossly, but repetitive microtrauma with the joint moving too much because, say, ligaments have been torn and they are no longer as strong and robust as they used to be, and they're allowing more motion. Every time you use that joint, your bones are translating a little bit too far in relation to each other. And this leads to earlier breakdown of joint integrity over time. And injuries can also cause chronic inflammation. And chronic inflammation can result in horrible arthritis, such as this. This is a specifically virulent form of arthritis that comes from a systemic pro-inflammatory state known as rheumatoid arthritis. And chronic inflammation creates a very destructive chemical microenvironment inside the joint, which totally destroys the joint. It kills the cells and it breaks down cartilage. So what are the treatment of orthopedic injuries? Well, they're the standard police protocols, which stands for protection, optimal loading, ice, compression, and elevation. And this is the acute triage, maybe with a little Tylenol, rest for a few days, and most injuries start to get better and over time will improve, and no worries. Then there is biophysical stimulation, and this actually stimulates repair of damaged tissue. But this mainly works in well-vascularized tissues. In other words, tissues that have a good blood supply and that are expected to heal without surgery or as an adjunct to surgery. And these are pretty much, we're talking slight tears in tendons or ligaments, and muscle injury, and bone fractures, from microfracture to gross comminuted fractures. And these modalities include physical therapies, cryotherapy, which is ice therapy, ultrasound, deep heat, laser therapy, and magnetic fields can do this as well. And these all can be helpful in healing. So the standard algorithm of treatment of injury starts with an injury. Basically, you do a little acute triage. That's a fancy word for taking some Tylenol, putting some ice on it, and elevating it and resting it for a few days. Most people get better. And when you don't, somebody will tell you to go see the doc, and the doc will say, hey, go see the physical therapist. They know what they're doing. And physical therapy can solve usually most of the rest of injuries that haven't responded to your remedies at home. But if after 4 weeks of physical therapy, you're still not better, you go back to the doc, doc sends you to the orthopedic, and the orthopedic says, well, hey, let's try a steroid injection. And they'll do a steroid injection, and sometimes that might just solve it. And it could solve it for years, but unfortunately, it often masks the underlying pathology and injury and makes people think that they are healed when in fact they are not. Nonetheless, it may work for a short period of time. It may work for weeks to months, sometimes even years, but then the pain comes back, you're back to the doc, and now what happens? They order an MRI. Well, if you're standing in a surgeon's office looking at an MRI, your chances of surgery go up 90%. Surgery tends to lead to more surgery, and if you have several surgeries on a joint, and give it a couple of decades, guess what happens then? Well, they replace the joint. That's the standard algorithm of treatment of orthopedic injuries. Well, we're going to talk more now about a new field of orthopedic medicine that works to take you out of that algorithm of treatment, pushing you towards total joint replacement. The ideal treatment of orthopedic injuries is maximize normal healing by maximizing angiogenesis, that word again. In other words, let's increase the blood supply. Number two, change the destructive chemical microenvironment causing cell death that is occurring inside a tissue or a joint that has been damaged. You want to reduce cartilage breakdown. You want to affect healthy, normal repair of tissues that are torn, and you want to support the cells alive in those tissues. Finally, you want to increase stability. Remember, injury and aging causes instability in a joint, and that will, without a doubt, destroy a joint. So you want to focus on increasing stability in any way you can. There are two forms of stability in any joint. One is static stabilization. Those are the ligaments that connect bone to bone. The other are the dynamic stabilizers. Those are the tendons that span a joint. And remember, tendons are attached to muscles, and dynamic stabilizers are stabilizers that you can strengthen in physical therapy. That's why we always send people to physical therapy, because they can strengthen dynamic stabilizers, which will go to a long way to increasing stability in an injured joint. In 2005, for the first time on Earth, medical doctors began treating these orthopedic injuries using precise stem cell injections. And what this led to was a new field of medicine. And this field is known as interventional orthopedics. So what is interventional orthopedics? Let's compare it to traditional orthopedics. In traditional orthopedics, they're using a lot of tools: scalpels, drills, saws. They're incising, cutting, grinding, amputating. They're placing screws, plates, rods, nails, anchors, staples, and sutures. The metaphor here is carpentry. As opposed to interventional orthopedics. What are we doing in interventional orthopedics? Well, we're only using needles. That's it. And needles and advanced imaging. And that advanced imaging is ultrasound and fluoroscopy, which is real-time X-ray. We are injecting. What are we injecting? We're injecting our patient's own blood and or repair cells into areas of damage. We are delivering growth factors to damaged tissues in the hopes that they will repair themselves. The metaphor here is gardening. In traditional orthopedics, you remove and rearrange tissues. You deconstruct and reconstruct those tissues, and you replace native structures. As opposed to interventional orthopedics, what we're doing is we're attempting to stimulate repair and to regrow healthy, normal tissue, thereby preserving native structures. This is a key concept, because I would posit to you that the design of the human body has been refined over many millenniums of time, and that design is sublime. And if you change it through orthopedic surgery, it comes at a cost. So what is the promise of interventional orthopedics? Well, the promise is the use of the body's ability to heal itself. Number one, it is minimally invasive, and the final result is that it preserves native tissues. Let's go back to the balancing act of a healthy joint. There is a balancing act between repair and maintenance forces and breakdown forces. On the repair and maintenance side, you've got healthy cells, you've got controlled remodeling of cartilage, you've got normal loads and stability, and you've got normal bone-cartilage interface. On the breakdown side, you have chondrocyte death. These are the cells alive in cartilage. You have uncontrolled cartilage breakdown. You have excessive loads and instability. And you have an abnormal bone-cartilage interface. This is another schematic showing the balancing act inside the joint. You've got forces that are degrading the joint versus forces that repair the joint. Let's start with degradation. What are some of the forces that degrade a joint? Well, you've got breakdown forces and you've got pro-inflammatory forces. Both of these factors, breakdown factors and pro-inflammatory factors, work to degrade a joint. Let's look at some of those. Breakdown. This is an arthritic knee. What you're looking at is a normal, fairly normal joint space here on the outside of the knee, but the inside of the knee, this is your proverbial bone on bone with little osteophytes on the edges. This is arthritis. It's fairly advanced. Well, what's happening inside a joint like this is that there is a destructive chemical microenvironment. And this joint, this arthritic joint, is digesting its own cartilage. How is it doing that? Well, the cells that are alive inside the cartilage that's left are producing proteolytic extracellular matrix enzymes that are digesting cartilage. And these little enzymes are known as MMPs, which stands for matrix metalloproteinases, or ADAMTs, which is atom metallopeptidases. Anyway, they're known by lots of names, and there's lots and lots of them. But what's happened is that these enzymes are just tearing up cartilage, and no new cartilage is being replaced. Other factors that degrade a joint, pro-inflammatory factors. The enzymes we just talked about, they are stimulated by pro-inflammatory states. So what are the inflammatory agents inside the joint? Well, they come with fancy names. IL-1 stands for interleukin-1. TNF-alpha is tumor necrosis factor alpha. And both of these agents, which are chemicals, enhance the activity of these enzymes, which are digesting your joint. And the joint is thereby dying. Let's go back to the schematic now. Let's talk about the real-life things that degrade a joint. Well, injury and instability. Injury-causing instability can lead to breakdown of a joint and degradation of a joint. Obesity increases the loading forces through a joint, and over time, without a doubt, will tear up a joint. Smoking, amongst the many bad things that smoking does, rapidly accelerating cartilage cell death and arthritis in a joint is another thing it does. Poor diets do the same thing. Poor fitness levels can contribute to the degradation of joints. Sedentary lifestyles. Your body, we are really made to labor, run, and work. And when we don't, we're a little bit more subjected to joint degeneration. If all of those are present and you're doing nothing to counteract them, you're tipping this balance towards degradation. But what we want to do is tip it towards repair. So let's look at the things that work towards repair. And these factors include anti-breakdown factors. And these are forces that restore a healthy chemical microenvironment inside a joint. And this healthy chemical microenvironment reduces cell death. Chemicals that counteract the pro-inflammatory environment and inhibit this enzymatic digestion of cartilage in joints. An amazing thing is that these chemicals are found in human blood. And we only knew about this about 10 to 15 years ago now. And there's a whole host of them. Here's a couple of them listed. Interleukin receptor antagonist protein, IRAP it's called. It binds to the pro-inflammatory agent that we just talked about, IL-1, and neutralizes it, so it reduces inflammation. And then you've got a whole host of what are called peptidase inhibitors, proteinase inhibitors. These are chemical inhibitors of those little enzymes that are destroying the joint. Alpha-2 macroglobulin, A2M, inhibits the action of these enzymes. So does TIMP, which is tissue inhibitor of metalloproteinases. So if you did nothing else to a painful joint except inject some serum into that joint that somehow had the red blood cells extruded from your preparation, you'd be doing a smart thing. Other factors that work towards repair in an injured tissue, damaged or degraded joint. These are factors that build up a joint, and primarily what we're talking about here are growth factors. Growth factors are powerful hormones. They are powerful cell signaling molecules that help to restore tissues after injury. They promote cell division and growth, and guess what? They increase angiogenesis. Again, it increases blood supply. It stimulates protein and matrix secretion. And some of these growth hormones are known as PDGF, platelet-derived growth factor, FGF, fibroblast growth factor, VEGF, vascular endothelial growth factor. There's many more. That's just 3 examples of them. And where do we get these growth factors? Well, in this new field of medicine, we're getting them from our patients. We're getting these repair and growth factors out of our patients' biological cells. We call these autologous, and autologous is a fancy word for self. These are self-repair tissues. They basically come in 2 forms. One is a small circulating blood cell we've already talked about called a platelet, and we get that from a simple blood draw. The other is an adult stem cell, and where we get them primarily is from bone marrow. What we're doing is we're manipulating these repair cells for use in injury, and we call them orthobiologics, and that term comes from a patient's biological tissue, which we are using to treat orthopedic injuries, orthobiologics. Here's an orthobiologic injection. This is a schematic of a shoulder, just showing you the tendons of the rotator cuff with, little needles drawn in, showing you how this works. But this is literally how it works. This is prolotherapy to the shoulder ligaments. What we're doing is we're injecting repair cells here. We're injecting PRP, or we're injecting bone marrow aspirate concentrate. And these are very precise injections, and that's the key word here, precise. You've got to deliver these cells right into the damaged areas. You can't just throw them into the joint over here and hope they're going to find their way, because that's not how it works. You have to inject the cartilage. You have to inject the torn muscles, tendons, and ligaments. You have to use advanced imaging and know how to use that to do this. You have to use ultrasound and fluoroscopy. What we're trying to do is stimulate an inflammatory repair process in these damaged tissues. What's the correct dose of repair cells? Well, now we're going right into the heart of this new field, and this is the key. We need to know what the dose is. Whenever a doctor is prescribing medicine, he needs to know what the dose is. What is the optimal dose? And where does he get that dose from? It comes from the evidence, the research that's been done in the field. Now, with stem cells, we're still not real sure of the dose, the proper dose. We have a rough idea, but we don't know the exact idea. We have a range. Primarily with stem cells, it's go big or go home, meaning more stem cells are better than less. You want to maximize the harvest, and that means you want to get as many stem cells out of the bone marrow as possible, and there are techniques to do that. With platelets, recent studies have shown what the correct dose is. And the correct dose is the dose that stimulates, again, that word, angiogenesis, the dose of platelets that stimulates the growth of new blood vessels in a damaged tissue. And that dose is 1.6 billion platelets per ml. And that's where I come in. It's my job to make sure we hit this concentration. We find that concentration by drawing your blood and getting a baseline platelet count. We multiply that by the amount of blood drawn, and we multiply that figure by the capture rate of the system that is being used, and that equals the dose, meaning it equals the number of platelets that you have. And remember, this is the dose that needs to be hit. Now, unfortunately, there are many, many people in this field, many doctors in this field, who are doing this work who have no idea what the dose is because they don't know how to count it. They don't know what the baseline platelet count is because they don't draw your blood and do a platelet count before they do their treatment. So they really have no idea. And this is one reason why the platelet research is all over the place, by the way. Let's go back to the healthy balancing act inside the joint. You come to see me, you've got I don't know, shoulder pain. You've been throwing too much. You were playing catch and you kind of overdid it because you don't normally play catch and you were throwing pretty hard. And now that shoulder really hurts. And I take a look and examine you and I think, okay, PRP should solve this. We'll inject the rotator cuff. It should be fine. I'll inject the subdeltoid bursa as well. What are we doing when we're injecting PRP into the rotator cuff tendons of the shoulder? Well, we're delivering a whole host of anti-breakdown factors, including the factors we just discussed, alpha-2 macroglobulin, IRAP, TGF-beta, tissue inhibitor of metalloproteinases. And we're getting at least one powerful growth factor, platelet-derived growth factor, which is a buildup force inside a degenerated tissue. So that's what you're getting here. And quite often that solves the issue. But if you come in with a bona fide tear and I put the ultrasound on and I take a look and then I order an MRI, and sure enough, you've got a tear in the supraspinatus extending into the infraspinatus, which are two of the rotator cuff tendons, I'm going to say to you, we probably need to use bone marrow for this. So let's say we do a bone marrow procedure, and what we get out of the bone marrow are MSCs, mesenchymal stem cells. What do we get when we inject stem cells? Well, we get a whole host of powerful growth factors, VEGF, FGF, IGF, CXCL. And by doing this kind of work, what we are doing is putting our finger on the scale and we're tipping it towards buildup and anti-breakdown. Prolotherapy is a technique that we're using, and this is the precise injection into tissues of damage. Now, prolotherapy as an injection technique has been around for about 90 years. It's defined as a growth factor or growth factor stimulating injection. Now, in the old days, we used to use 12.5% dextrose, which is sugar water. It's irritating and pro-inflammatory. And if you injected, and if it still do, if you inject dextrose into a tissue, it causes inflammation and triggers a repair process. The revolution in my field, this new field of orthopedics called interventional orthopedics, is that we discovered that injecting a patient's repair cells causes this technique to be that much more effective, quite dramatically so. Prolotherapy can thicken ligaments and tendons and help them to repair themselves if they're torn. If you do this to ligaments and tendons that span a joint, you can increase stability and you can reduce the progression following injury to post-traumatic arthritis with this injection technique known as prolotherapy. Here's a couple of examples of it. This is the injection of the psoas tendon, which is the tendon of the largest muscle in your body, which is the hip flexor. It's known as the psoas. This is an ultrasound view. What you're looking at here, this white streak, this white curved streak, is the ball joint of the hip. And this streak here is the cup that this ball joint is fitting into. So this is bone, this is bone. This is the psoas tendon going over the top of it. And if you see in the middle of the tendon is this hypoechogenic line, this black line. Well, that's a tear in the tendon that I'm treating here. And when I run this little video, you're going to see a very faint outline of the needle coming right into this area. And then you'll see a flash of white here, which is the injection of the PRP. Here we go. There comes the needle. The needle's right here. And here comes the flash. You'll see it right here. Boom, right there, right into the tear. There it is again. This is the needle, very faint. And this is the injectate going into this tear, this dark line right here. Here's another view. This is the shoulder, a supraspinatus tendon, rotator cuff in the shoulder. Again, this dark line is the ball joint of the shoulder. This is the deltoid muscle going over the top. This white thing here is the tendon. And you're going to see the needle come in right here. This is the needle. There's a tendon. That flash of white is the PRP going into the tendon. So you see how specific this is and how you have to look directly at it to hit it and get it right. We perform precise image-guided stem cell and platelet procedures to treat. What do we treat? Well, we treat headaches, we treat neck pain, we treat upper back pain, we treat shoulder arthritis, rotator cuff tears, and shoulder labral tears. We treat wrist and thumb arthritis, elbow arthritis. We treat low back pain, sciatica, facet syndrome, disc herniations, bulges, and we treat stenosis. We treat hip arthritis and labral tears. We treat knee arthritis, meniscal tears, ACL tears. And what's this last one here? I have to move us to see it. Ankle arthritis, ligament and tendon tears. There's, basically not a joint in the body that I don't treat. I am fellowship trained in spine and sports as well. Here are some examples of what we're doing in the clinic. This is a C-arm fluoroscope around a patient heavily draped. This is a patient's knee. And this is the fluoroscopic view we have of that knee. And if you look closely here, you can see the needles going in. And here, of course, you can see them. This is a trocar that we have placed inside the kneecap, the bone. And this is a needle that's going right behind the kneecap into the articular anterior joint of the knee, the patellofemoral joint. This is the MRI of that knee, and this is why we're injecting the kneecap, because of this white bone lesion. And we're injecting bone marrow into the kneecap. And you can see that the cartilage, which is this gray streak, is what we call chondromalacia. It's softening and breaking up. And what we're injecting behind that is, again, stem cells. This dark little streak here is dye that's being injected to show me where the bone marrow will go once I inject it. And we're going to deliver bone marrow right into the kneecap, right into this lesion. But this is the elaborate setup that we quite often perform in clinic to hit these targets. And again, that's the key here. You've got to place these repair cells right where they're needed. This is an injection into the shoulder. This shows 2 real-time placements under fluoroscopy. The first placement is into the shoulder joint, and this dark streak here shows the glenohumeral joint. The second placement of the needle is this little triangular thing of dye. That's the labrum. So we're treating a joint, the shoulder joint, and then we're treating the labrum of the joint. Again, showing the precision of the injections. This one is really cool. This is hydrodissection of the median nerve. This is a highly magnified view of the wrist. This is the median nerve. And this is the needle coming in that's going to hydrodissect the median nerve. Watch this. There's the needle, and we're injecting platelets around it. This is the size of a green pea. It shows you how delicate this work can be. This is the median nerve. It's about the size of a pea, a little bit smaller. Again, the precision of what it is we're doing. It requires direct visualization. Can't be done otherwise. You do not do these injections blind. Why will interventional orthopedics replace elective orthopedic surgery? Why is that? Well, that's because, why do I keep going backward here? That's because it's less invasive than surgery. It involves a much quicker recovery than surgery. And the final result is that unlike surgery, it preserves native tissues and does not create scar tissue. Let's go back to the algorithm of treatment here. The algorithm is the same up until we get an MRI. Now, if you're standing in my office and we get an MRI, your chances of getting an orthobiologic injection go up 90%. I may suggest that we do a procedure. We'll do that procedure, and the first thing I'm going to do is send you back to physical therapy. We're going to give it some time, and when this works, as it quite often does, like a charm, what we have effectively done is we have preserved the native tissue and or the joint. And what we've effectively done is taken you out of this algorithm that is pushing you inexorably towards joint replacement. That's the promise. That's the true promise of interventional orthopedics. And that's really why, and my joy of practicing medicine, is to affect this change in the algorithm. The final thing I want to leave you with is that the treatments that we do in my office are not what we call a terminal treatment. What's a terminal treatment? A terminal treatment is joint replacement. Once you've had the joint replaced, there's nowhere else you can go. You can re-replace the joint. No surgeon on earth wants to. But if you've had it for 25 or 30 years and it gets broken down, or God forbid it gets infected, it's got to be re-replaced. And it never works as good as the first replacement. So that's a terminal treatment. In other words, there's nothing else we can do. We've replaced your joint. There's no other options for you. With an orthobiologic injection, none of your options are limited. If after an orthobiologic injection you feel you need to have surgery, you can have surgery. And there's not a darn thing we have done to limit your chances of success when you go to surgery. You can go to joint replacement. You can go back to physical therapy again. This is not a terminal treatment like a total joint replacement is a terminal treatment. Well, that concludes my presentation, and I hope I haven't been overly long and dilatory, but I realize that took a while. So I thank you so much for your patience. This is how you schedule an evaluation with me. You can find us online at ioct.info. This is a phone number, gets you right to Patty. And this is Patty's email. I want to thank you once again for spending this much of your precious time on a Tuesday night with me. I want to go back to, let's see. Yeah, I just want to go back to the we'll just end it here. If anybody has any questions, please jot it down in the chat box here, and I'm happy to answer them. I realize that was a little deep in the weeds, and that's one of the problems. You get me going on this subject, and I can talk for quite some time. That's how I spend the majority of my days, is talking about this new field of medicine, because it's only been around since 2005, and that may seem like a long time. That's just a blink of an eye in medicine. Um, the research in the field is growing. It's very exciting stuff. I mean, I've been practicing medicine for so long. Typically physicians my age would be retired, but because I've only been doing orthobiologics for about a decade now, I'm very energized. Um, I'm very excited about what I do, and I'm continuing to practice. We do have a question. Is it possible to regenerate cartilage? That's a very good question. This is from Amanda. It's a very good question, Amanda. We still have not figured out how to regenerate the pristine standard issue cartilage, the cartilage that you were born with. That's known as hyaline cartilage. We do not know how to stimulate the regrowth of hyaline cartilage. Scientific bench work indicates that it's an extremely complicated process over many, many days and weeks, requiring precise injections of chemicals in precise amounts at precise intervals, precise periods of time. So very, very complicated relative to what it is we're doing now. So the long answer is no, we cannot regrow hyaline cartilage. I can stimulate a form of repair cartilage. This is known as fibrocartilage, and that's different than the pristine, beautiful, pink, glistening native cartilage known as hyaline cartilage. But you know what? Quite often it's enough. Quite often it's enough to get athletes back in the field and people walking around with little to no pain after spending many, many years having lots and lots of pain. So yes, we can regrow a form of cartilage, not the standard issue cartilage, hyaline cartilage. We've yet to figure that out. That's for the next generation, maybe. Question from Jim. How successful is your approach with patients who have autoimmune diseases? Another excellent question. Very difficult. If you're not an immune patient, you understand the difficulty. You have a pro-inflammatory systemic disease in which your own body is attacking yourself. So yes, it can be helpful. Can we solve the autoimmune problem? No, we cannot. But I treat a lot of rheumatoid arthritis patients. I've treated lots of patients with Sjogren's, with ankylosing spondylitis. And yes, this is a very helpful modality. It beats the heck out of steroids, which is a flash in the pan effect. It lasts anywhere for a couple of days, couple of weeks, maybe. This kind of work, we can really dial down the rheostat on the chronic pain that people with these pro-inflammatory systemic states are suffering. So is it great? Is it curable? No, it's not, but it can be very helpful. Yes. And again, it's a rational, smart thing to do. Steroids are not. Steroids are terrible for anybody. They're just toxic to the human body and shouldn't be used repeatedly. Question from Arlene. Will this work on a torn labrum on the groin side of the hip? Yes. Yes, it will. Yes, it can. Catherine, question from Catherine. What research studies do you recommend someone reads regarding this topic? What are some reasons you would choose stem cells over PRP, and what are potential risks for both? Can you also perform this for osteoarthritis? The answer is yes, we can perform this for osteoarthritis. The criteria for stem cells versus PRP in general, lesser forms of arthritis, smaller tears in tissue, ligaments and tendons, can be handled by platelets. More advanced forms of arthritis, larger tears, ruptures, ACL ruptures, completely torn rotator cuffs, these require bone marrow. That's a rough answer there. What studies would I recommend? Well, there are many, and I can't get into the weeds here about actually giving the, and I know the presentation didn't list any. I have other presentations where I'm quoting these studies and I do list the citations. I don't have those. If you want to go to NIH and just, if you know what that is, the National Library of Medicine. If you want to go there and just put in your search engine stem cells for joint pain, stem cells for arthritis, PRP for arthritis, a whole host of studies are going to come up, so you can begin to read about this. But if you come into the clinic, we can send you some more specific citations if you're that interested, which would be unusual. Most people aren't. Mrs. B, do you recommend supplements to support bones or healthier joints? No, I don't. No, I recommend exercise and fitness, and I recommend a healthy, mostly plant-based diet. I don't believe in supplements. I think they're a waste of time, and we don't understand how they work. How you can take chondroitin sulfate and glucosamine, which are two of the very large viscous substances that go up to make the ground substance in any healthy joint, how you can take them by swallowing them, and they go through the hell of the digestive process and enzymes in the stomach, and then somehow find their way in tiny little pieces to a knee or a shoulder and help you get better. We don't understand that. I don't. So I'm not a great believer in supplements. Never was and never will be. Joyce has a question. Where do you draw the bone marrow from? What part of the body? We get it from the iliac crests. If you want to look that up, the iliac crests are the large bones on either side of your hip. If you just reach down to your belt and go down to the first bone you hit, that's the iliac crest. That's where we get the bone marrow. I can get bone marrow from any bone in your body. We get it from there because there's a lot of marrow there and there's not a lot of nerves or blood vessels we have to worry about. So the iliac crest is the answer. That's where we get the bone marrow. I know it sounds like a horrible process. It really isn't, but most civilians coming in think that that's got to be terribly painful. It is not. If you know what you're doing and you spend the first 15 minutes of the procedure numbing the patient up, patient just feels a little bit of pressure. You don't feel the trocar going through the cortical bone to get to the marrow. They don't feel that. I know it sounds awful, but it really is not. I've had it done personally 4 times, and I've done it quite literally several thousand times in patients. Irene has a question. Who can benefit from A2M injections? Would this work on severe osteoarthritis? The more severe forms of osteoarthritis are more challenging, and there are criteria that make you a bad candidate. When you walk into my office, I basically put you into one of 3 cans: poor, good, poor, fair, good. And that means, how good a candidate are you for what I do? If you walk in and one bone is slipped off of another and there's no cartilage left and the bone is remodeling and grossly unstable, I'm going to tell you, you need to save your money. I can't help you. You need to have this joint replaced, and you'll be very happy if you do, and I'm happy to refer you to the best surgeons I know. So very severe forms of arthritis, no, we're not successful. So the take-home message is don't wait until the arthritis is severe. Come in sooner than that, because we'll take you out of that algorithm that pushes you toward joint replacement and increase your chances tremendously that you will leave this earth with all of your native joints and all of your native parts. And no surgeon would be putting screws, plates, and prostheses into your body. It won't be necessary. A2M injections. When I first started doing this a decade ago, I did some ATM injections, but then I read the literature and I realized that ATM is in every bit of serum, blood serum, human serum that I inject along with the platelets. And there's no need to do a specific A2M preparation because you're getting A2M along with the platelets I'm giving you. So it has been years since I've done an A2M only solo injection. I don't do them anymore. Plus, the preparation for A2M takes a long time. But the concentration of A2M in all healthy serum is at a level that we believe to be therapeutic. So, you can do A2M injections where you concentrate it further, but there's no literature that I know of that says that works better than platelets or better than stem cells. So no, I don't. Long story short, I don't do A2M injections, solo A2M injections. But every injection of platelets you get, you're getting A2M. Okay, any other questions? I think I've answered everybody's questions. I hope I didn't miss any. If you have any more questions, um, go ahead and type them in. Happy to answer them. This is something I spend the majority of my days doing, by the way, is talking to patients and answering their questions and doing a lot of explaining. Which is a point I should bring up. If you come to see me, I consider myself your medical guide in this field. I'm very upfront about what I do and what I believe is correct to do. But if I feel that I can't help you, it's, you're paying me money to get my opinion. I will give you my opinion. If I don't think that you are a good candidate, I will tell you. And I will tell you because I am one of a small cadre of physicians in this country who are dedicated to moving this field forward. And those of us who are, we need to make a living, of course, but we have no interest in doing this in patients that we know it probably won't work well for. So I'll give you an honest opinion as to whether I think it will work or whether it will not for you. I will tell you if you fall into the, good, fair, or poor categories. If you're in the poor category, basically, I tell you, don't do this. Go talk to a surgeon. But I'm happy to also lay out all of your options, including surgery, including watching and waiting, including physical therapy, including electric shock wave therapy, and the relative effectiveness of these and how they might work together. But I got to say, the reason I do what I do is that for the most part, bone marrow injections and platelet injections can be very effective for a whole host of orthopedic injuries and conditions, including arthritis, including fairly severe forms of arthritis too. It really depends on what you mean by severe. That's not a very descriptive term. If you start talking to me technically about what you're seeing on an MRI, I can tell you right back whether I think you're a good candidate or not. Let's see. I think we have a couple more questions. Can you do more than one joint at a time? Good question. It depends on what we're doing and how much repair cell and tissue I need for each joint. Now, tomorrow, for example, I'm going to do a bone marrow procedure on 2 thumbs. No problem. Bone marrow procedure with bone augmentations on 2 knees? No, I can't do that. I got to do 1 knee at a time. I know that's a bit technical, but it requires a lot of bone marrow. And I'm limited. Depending on your size, your gender, your age, I can only get so much bone marrow at a time from you. So that typically means that on a knee, if I'm going to do bone augmentations in those knees, I can only do 1 knee at a time. So quite often what happens is when I have 2 knees or 2 joints that I have to do and I don't feel I have enough, I'll tell the patient, well, look, let's focus on the bad one, the bad joint, the really bad joint for now, and I'll do everything I feel that needs to be done on that joint. And then I'll save a little bit of tissue left, and I will treat the other joint very briefly before we, stop the procedure, because that's all the material that I have. So that's often how I'll deal with that. But it really depends on what we're treating, how bad it is, and what tissue we're using. Elaine has a question. Can you help second-degree spondy? I think you mean spondylolisthesis. That's my guess. In the spine, a grade 2. The answer to that is yes. Yes, we can. We need to inject the ligaments that hold the spine together, particularly at that level where you're slipping, where you have the spondylolisthesis. We tighten up those ligaments, and we cannot reduce it. We don't bring the bone back after it has slipped, but we stop it from slipping further. We give you more stability at that level. So yes, the answer, Elaine, is that I can treat that. Jim has a question. How long does this therapy usually take? How long before you get results? That's an excellent question, Jim. The toughest part of these procedures, I quite often tell patients, is the waiting for tissue change to occur. Tissue change time begins, on average, after a platelet injection, 2 to 4 weeks. After a bone marrow procedure, platelet tissue growth time begins, well, at least according to the literature, the first blip up in the data following bone marrow procedures occurs typically between 8 and 12 weeks. So that's 2 to 3 months afterwards. And that's frustrating for patients, and I speak personally, when I've had this work done, I find myself, I'm the doctor and I know what I'm doing and I know what the process is. I'm still walking to the calendar going, when's this going to work? When am I going to feel better? And what typically happens is around week after a bone marrow procedure, around week 8, 9, 10, 11, 12, 13, you kind of go, oh, wait a minute, that didn't hurt. Oh, wow, that didn't hurt. And it suddenly sneaks up on you. And then it gets better from there. That's a typical response pattern. We do these procedures, bone marrow procedures. People follow up at 4 weeks. That's pro forma. That's just for me to basically say, everything okay? Great, let's start physical therapy. I'm not looking for improvement. And a lot of patients, even despite all the yak that I give them before the procedure, they misunderstand and they come in at 4 weeks and, oh God, doc, it didn't work. It's not working. It didn't work. It's like, whoa, 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 wait a minute. It's only 4 weeks. You got to give it more time. So it takes time is the answer. We expect a quicker resolution with platelets. I don't pass judgment on a platelets procedure for about 6 to 8 weeks. I don't pass judgment on a bone marrow procedure for 4 to 6 months after I do it. So, you got to keep that in mind. You have to factor that in. This is not like a steroid injection, which, I inject you on Tuesday, and by Thursday, you're singing my praises and thinking that that joint or tissue is 20 years old again, and you can do whatever you want. It's a false sense of security, and that's not how this kind of thing works. But there's often a two-phase response. Sometimes I will do this, and patients will come back, after a couple of weeks, even 4 weeks after a bone marrow procedure, and say, you know what, I'm already a lot better. And you know what that is? That's the change in the chemical microenvironment that I have affected by injecting your repair tissues into a damaged joint. And that happens very quickly. Inhibiting the enzymes that are digesting a joint, that can happen very quickly. So that people do say quite often after a week, oh, I'm already feeling better, doc. That's what that is. That is not tissue change. That's a chemical change in microenvironment. That's not tissue change yet. And that's what I'm interested in, tissue change. Because if I can get the tissue changed, that's where we get the long-term improvement of years down the road. And that's what I'm after. So patience is required. Amanda had a question. Is that Colorado in your background? Yes, it is. Those are the Flatirons back there. This is outside of Broomfield. Elaine, how about severe spinal disc degeneration? Depends on what severe is. Again, that word, severe. Really severe, we do what's called a degenerative disease protocol, and that's where we inject all around that the motion segment, which is a vertebral body, the degenerated disc, and a vertebral body below it, okay? And we will inject all the ligaments that hold that motion segment together. I'll inject the facet joints that are at that level that are probably very arthritic and very painful, and we'll do an epidural injection of platelets at that level as well. And when you do all of that, yes, you can get quite dramatic improvement. If it's not so severe, it depends on who's using that term and what it is. I can go directly into the disc and I can treat the disc. And these are some of the greatest successes that I have had in my practice, is injecting discs that are painful and bringing them back around and making them non-painful. And I love to do it, but there are criteria for it. So yeah, I need to look and see what your MRI is showing me. And then I'll tell you, yeah, I can inject this disc or I can't. And if I can't inject the disc, there's still a lot more I can do to mitigate the symptoms that collapsed disc is causing. How about bilateral spinal stenosis? I assume you're referring to bilateral foraminal stenosis. Yes, we can treat that. Yes, we can. Anonymous attendee asks, is this treatment good for an injured Achilles tendon? You bet it is. You bet it is. That's one of my most recent success stories. A gentleman came into my office and across the street at a wedding up in Boston, and badly tore his Achilles tendon. And it just looked like heck, and he wasn't walking well, and he was very disappointed and upset. And there was, real reluctance on the surgeon's part to repair this because it wasn't completely torn, and they didn't want to mess with it. And I believe he had a comorbid condition, which also made surgeons not want to touch him. So we did bone marrow with a fat graft into this Achilles tendon, and he's a much happier guy now, I can tell you. And I'm quite impressed with the results that we got out of that one particular procedure. So yes, again, long story short, we can treat Achilles tendon tears. Anonymous has another question. Are these treatments covered by insurance, notably Medicare? No, they are not. No, they are not. Medicine is a very conservative business. We've only been doing this for about 20 years. That's the blink of an eye in a very conservative field. I do have some motivated third-party payers, notably workers' comp. They pay me for these procedures because they've been around the block with orthopedic surgery and spent tons of thousands of dollars and not gotten their clients back to work. And they've learned that if they send them to me, their chances of me getting that client back to work for a fraction of the cost of surgery is a good trade-off. And so they pay me for what I do. But no, you don't have Medicare paying for this because you don't have Blue Cross Blue Shield paying for this. You don't have United Healthcare paying for this. They're dodging this. They don't. And the reason they're dodging this, there's many, many reasons for that. And I'm happy to go into that at some point if you come into my office and have further questions about it. But no, frankly, no. Insurances don't pay. This is mainly a cash on the barrelhead proposition. And to that end, I might add there's a lot of fraud here. You need to be careful. If you go to somebody down the block who says, you know, hey, we're having a sale, we'll inject stem cells into your joint. Two basic things you want to make sure of. A, they're your stem cells. And B, the person doing this is a medical doctor. Okay, very important. You don't have chiropractors do this. You don't want to have mid-levels do this. You want to have someone who is a medical doctor who's trained to do this. And believe me, there's not many of us. Elaine has a question. How many PRP injections needed? That's all relative. But one of the caveats I always tell patients is, you know, we all want it to be one and done, particularly when you're paying for this out of your pocket. But you need to be aware that sometimes it requires more than one treatment. In my clinic, I never tell you when you walk in the door, I never look at you rarely and say, oh, you need 3 treatments. I do that once in a while. If you come in with a wildly unstable joint that I feel I need to get stable, I will say, before we even get to bone marrow, you need to do 3 PRP or prolotherapy with dextrose injections over the course of, 6 weeks, 2 weeks apart. And then we'll talk about doing bone marrow to get you ready for the bone marrow. But typically, in my office, you do a treatment and you wait that period of time I told you about, which is typically 6 to 8 weeks after a platelet procedure, 4 to 6 months after a bone marrow procedure, and you reevaluate. Do we need more treatment? Sometimes it's necessary, yes. Catherine has a question. If there is an injury in C2, can you inject that? If not, would injecting lower facet joints still benefit the patient? C2-3 facet joint is a facet joint that I inject routinely. So yes, the answer is yes, I can inject that. That's not a problem. Can I inject lower joints? Sure. Can I inject higher joints? Yes, I can inject higher joints as well. Remember, not a joint in the body that I don't inject. Do you accept other physicians' X-ray and MRI? Oh, certainly. Yeah, certainly, if they're adequate. And they are recent enough. I mean, if you walk in the door and your MRI is from 2018, I'm going to tell you that's ancient history. I need to see what it looks like now. And I'll order one. If you need an X-ray, I'll take one in office. We don't do MRIs in office, but I need an MRI. That's what that and examination can, allow me to really put you into one of those 3 buckets and tell you whether I think you're a good candidate for what I do or not, and exactly what we need to do. Bone marrow versus platelets or both. So an MRI is kind of key, quite typically. But yeah, if somebody else has ordered it and you have it, bring it with you. Give me the password to your health portal so that I can take a look at it, and I'm happy to do that too. We do evaluations in office and we do evaluations remotely like this via Zoom quite frequently, particularly for people who are coming from a long distance away. And for the most part, after listening to them talk and asking very probing questions and looking at their MRI of the joint, I quite often know exactly what needs to be done, and I can send a proposal based on that, with the caveat that if it needs to change when you come into my office and I spend the first 30 minutes examining you, if I feel something needs to change, we'll change it. That typically doesn't happen. Quite usually I can, with an MRI and with a patient's history and what they're telling me and the MRI, I can make a pretty darn good diagnosis and know in the majority what I need to do. So yes, an MRI is key, and yes, I will accept an MRI from another doctor. Any other questions? Anybody? Great questions, folks. I really appreciate them. You're obviously thinking hard about this. Just a word about my practice model. If you want to come in for an evaluation, we will take your insurance. If you've never had a steroid injection, and I feel that one is necessary and kind of the standard approach, I'll do one. I won't do another. I'll do one. And we'll do all of that under your insurance. Okay? We only start talking about money out of your pocket if we're going to do PRP or bone marrow. But the evaluation, we do that under your insurance. So whatever your deductible is, you can come see me and get an opinion, and we're happy to bill your insurance for that. And if I treat you or order an MRI or think a brace is good for you and give you a brace, we'll charge your insurance for all of that. The point at which we veer away from the standard practice of orthopedics into the fields of orthobiologics, only then do we leave your insurance behind. But there's no, I'm not requiring some huge lump sum of cash out of your pocket to see you or to look at your MRI and give you an opinion. That we do under your insurance. So be clear about that. I've had that hybrid model for years. It's always worked great. People work hard for their insurance. They want to use it. I'm happy to accept it when I can. I just can't accept what they would pay me. They wouldn't pay me if I submitted my bill for orthobiologics. They have no idea what I'm doing right now. They really have no idea. So that's a separate issue. And this is always done via proposals that we send to your email. We always want to make it clear that you're seeing a medical doctor, and I'm not a used car salesman. We never, ever want to be accused of twisting somebody's arm. We don't run sales per se. I realize, kind of laugh when I say that because we have started doing some cosmetic procedures, and we are offering an introductory rate on those. I've started doing those, frankly, because patients push me to do them. But when it comes to orthopedic medicine, we send you a proposal. You look over at in the privacy of your home, and if you have questions, you're encouraged to call. You need to be comfortable with what you're doing with me going forward. And it's my job to make you comfortable. If you're not comfortable, then you don't treat with me. Simple as that. Any other questions? Approximate cost of PRP. Yeah, we always get asked this question, and it's impossible to answer. It's impossible to answer. PRP injection into what? And how badly is that what damaged? Almost impossible for me to answer. Much cheaper than a bone marrow procedure. Cheapest PRP procedure I do starts at about $1,200. A single joint runs around $1,500. PRP can go up to $3,500, $4,500. Bone marrow procedures tend to start at about $5,000, and they do go up from there, depending on how much damage, what I have to do, if I have to do bone augmentation as well, how many ligaments I have to do. All of this has to do with, it's not PRP. Here's PRP. This is the cost of it. We'll do it here, there, and there. No, that's not the way it works. It requires a proper diagnosis, knowing exactly what needs to be injected. And then depending on that and how much PRP I need and how much time I'm going to spend doing the procedure, that's what you're going to pay me for. So it's hard to say how much for a PRP. It really depends. Mrs. B, I'd hope over time you could convince insurance companies with your success of the process to reevaluate this process. It's exactly what we're doing, Ms. B. It's exactly what we're doing. Those of us who are in this field, who are dedicated and follow the research in this field, there's already robust studies that indicate that what we're doing is not voodoo, that it's very effective, and that it's a fraction of the cost of surgery. Smart insurances would typically, read this and be swayed, and we're in the process of doing that. But medicine is a conservative field. As I said earlier, it's going to take time for insurances to come around, but I'm convinced that they will. And of course, I'm drinking the Kool-Aid. Why do I say that they will come around? because I know that this is not voodoo. I know that this is effective because I've done it for 10 years now. And I also know it's a fraction of the cost of surgery. And when insurances figure that out, that, we don't have to repair all rotator cuff tears, all meniscal tears, or all ACL tears and knees, because Dr. Southern and doctors like him can do this with bone marrow through the skin with a needle at a fraction of the cost of surgery, they're going to say, sign me up. Why do I know this? Because like you, I know insurances are all about money. They're really not about your health. They're about bottom line dollars and satisfying their investors. So when they figure out this is a fraction of the cost of orthopedic surgery and can be just as effective depending upon the pathology we're talking about, they're going to jump on board. So it's coming. Unfortunately, we're in the vanguard now, and still we don't have robust reimbursement by third-party payers. Any other questions? All right. Well, once again, I thank everybody for coming out. I've enjoyed it. I hope you have, and I hope you've gotten something out of it. And once again, if you are interested in a diagnosis and in a recommendation for treatment, please come see me. I'm happy to give you my opinion. No pressure. All right, everybody. Have a great night. Take care. Be well.